Good morning, all. I am Yolanda Whitty, Gaspin board member since 2014 and Gaspin newsletter co-editor. It is my pleasure to introduce our first speaker, Jessica Monczka, who will present on micronutrients for home parenteral nutrition patients. Just a quick background on Jessica. She has been practicing as a nutrition support dietitian for 20 years. Her background includes extensive experience prescribing parenteral nutrition for the adult, pediatric, and NICU populations, from critical care to the clinic. In the early years of her career, Jessica was fortunate to have a great mentor who taught her how to prescribe parenteral nutrition. Now Jessica enjoys leading classes and workshops on parenteral nutrition order writing for her colleagues. Jessica resides in Colorado and spends all of her free time on outdoor activities.
Good morning. Thank you so much for that introduction. Can someone just confirm real quick for me that they can see my slide there as it should look?
Yes.
Yes. Thank you. Thank you so much for that reassurance. I appreciate it. Yes, so as you can see maybe from my slides, I did visit the Gaspin website. It looks fantastic. I know that's a lot of work to get that going, so congratulations to all of you. And I stole a screenshot from it for my first slide here. So I'm assuming that is the skyline. Actually, I think I do remember this building from driving through town. So this morning, I would like to kind of take a trip through time and explore some of the literature we have on micronutrients in long-term home parenteral nutrition patients. So that's a pretty broad topic, right? So obviously we cannot review all of the literature that's available, but what I would like to do is kind of highlight some of the more interesting findings and developments that we have seen in this area through the years, and just really get us thinking critically about how we practice and kind of thinking, oh, well, I've always done it this way, but gosh, maybe with, you know, the developments and what's commercially available, I should take another look at this. So we will go over what we have available today in the marketplace for providing micronutrients to our home PN patients, and what we think might be the optimal doses, and we can kind of discuss that and ask questions about that and things. And we'll take a look at some of the practical aspects of administering micronutrients in the home, since our focus for the next hour will be on these home patients. It's always important, of course, to think about the patient at the receiving end of the therapy. We do that in the hospital too, but I just think that when we're talking about patients at home, it is absolutely essential that we think about how this affects them, because honestly, they're the ones who are at home putting their nutrition therapy together every day before they can hang their bags. We need to keep that in mind when we're thinking about these perfect prescriptions that we're writing for them. So as we get started this morning, I do want to let you know that the slide deck is updated from the version that's attached. Don't worry too much about taking notes. I will send out the updated version of the slides as soon as I'm finished. If it's possible, I'll just attach it to this platform so you'll have them, but I will make sure they get there and on the website. So don't worry about writing down a ton of notes. I will get any updates to you. So I would just say, you know, it's Friday morning, it's early, fairly early still. You know, I would sit back and have a cup of coffee and take a listen and kind of just follow the discussion. And like I said, you'll have the slides to follow up with later, the full slide deck. So I do enjoy history, and I think it's always important for us to understand our history and where we've come from in order to truly have a grasp on where we are today with our clinical knowledge and really figure out what's next. So I just want to take a second to go back to 1960s Pennsylvania. These are some screenshots of Dr. Dudrick and his famous TPN puppies, of course, and just remind everyone that, you know, TPN was really created in kind of fits and starts. You know, we didn't have this complete formulation. We had maybe some dextrose and some amino acids, maybe put some calcium in there. They were really, you know, he was working hard in the lab, as were his colleagues, to try to figure out how to get these compounds to even stay together in that bag and not have these chemical reactions and not precipitate out. And as they began to take care of people and not just the puppies, they really started to learn more about deficiencies, and that helped grow their understanding of the various micronutrients that really must be included in the prescription. So they kept working in the lab, testing out these various compounds, trying to get this admixture with adequate amounts of macronutrients, electrolytes, vitamins, and minerals. And honestly, I think in some ways we are still trying to figure out that optimal combination today, and we are still trying to make sure that it's safe and stable. And that's even more important for our home patients, because we are sending them, you know, we're not just mixing the day's bag and sending it up to the floor, we're sending a week's worth at a time. So we really have to always keep an eye on the safety and stability factors inside the bag. Another interesting thing I just wanted to mention, because TPN is pretty unique, where you can actually separate out each individual nutrient, and that can lead to deficiencies that wouldn't normally be seen. And we've learned from that through the years, as I'll talk about. But just a quick example to get you thinking about this. If you have written TPN for very long in the hospital, I would guess that you've been in a situation where you have been asked to remove like all of the calcium from the TPN, for example. Maybe the patient has a high calcium for whatever reason, whatever medical thing is going on with them, and the team looks at you and says, oh, let's take the calcium out of their TPN, because we can, right? It's a line item ingredient that can be removed. So that's not something we would be able to do with an oral or an enteral diet, really, but with TPN we can do it. But does that mean we should do that? I just wanted to throw that out there. All right, so as we started to utilize TPN more in the 1970s, we experienced kind of this rapid knowledge expansion. I just have a few examples of some of these papers that were coming out then, of case reports. So like I said, the TPN was not this complete full admixture like we have today. We didn't really know what all needed to be in there, so we started to learn as we started to give it to these patients. So on the left side of your screen are some of those early reports. And as we started utilizing TPN more and more patients were being treated, we were starting to see signs of deficiencies of some of the micronutrients. So in 1977, this is a screenshot from that paper, there was a nutrition advisory group within the American Medical Association that came together. There were physicians, biochemists, pharmacists, and representatives from the FDA, the pharmacopoeia, and the pharmaceutical industry, and they all came together to come up with recommendations for trace elements in particular in TPN. They knew, based on some of these reports that we were seeing, that we needed to have a consensus on what types of trace elements needed to be included in the TPN. So what came out of that was a recommendation to add zinc, copper, manganese, chromium, and then a little while later, selenium. So in the years since, we have been able to evaluate more and more long-term patients, and we've learned a lot more about their micronutrient needs. So there were additional recommendations made, and this is actually a follow-up to that. The initials were 2012, this is 2015, call to action because things weren't happening still. But recommendations were made to reduce copper, manganese, and chromium doses. But there wasn't a lot of movement on that for a long time. But now, finally, in the past year, we actually have had some new multiple trace element products come to market that are much more closely aligned with some of these recommendations that the various groups have been making for years. So we know that micronutrients are essential. We know that they're required for metabolism and for utilization of the macronutrients. They're cofactors and coenzymes. So we need to make sure that we're not only dosing them appropriately, but the proportions are correct. So there's a lot to unpack there with dosing micronutrients. And this is a problem that we still struggle with today. All right, so before we get too far in, I want to have a polling question, if we can pop that up, just to kind of get us a little more interactive. I know that we're virtual again this year, but I want to just get as interactive as I can in this virtual environment. So think about this patient for a minute, and you should have a little pop-up maybe coming up to open a poll section in your app there. Let's see if I can open mine. I'm not sure if I can get it open, but all right, so you have a long-term home parenteral nutrition patient. They're complaining of fatigue, and their blood work is showing unexplained pancytopenia. There is a national shortage of multiple trace elements, and they have not been added to the home parenteral nutrition bag for several months. So which deficiency are you initially suspecting? I can't actually see the poll results, so I'm just going to continue talking, but go ahead and keep answering. It will be interesting for me to look later and kind of see what people are thinking on this, but I'm just going to move on in the interest of time. So some of the things that we've learned through the years have been during shortages, and some have been with clinical practice changes that have led to widespread dosing adjustments. So these shortages and these dosing adjustments have really helped us and continue to help us fine-tune our understanding of daily needs. So this is an interesting story that goes along those lines. So for a long time, we were reducing or even eliminating the copper and manganese from TPN as soon as patients developed elevated bilirubin levels. Knowing that those two had a biliary path of elimination, it just made sense that we would not want to give them in standard doses to patients who were experiencing hepatic insufficiency. However, we learned from this. This was a widely accepted practice, but we learned and we started to see these reports of patients, especially pediatric patients, who were becoming copper deficient. So we knew that maybe we needed to take a closer look there and maybe refine our practice. Pediatric patients were developing anemia, neutropenia, thrombocytopenia, and osteopenia, kind of the classic signs of copper deficiency. And when they were provided therapeutic copper supplementation, their clinical symptoms improved, which helped confirm that that was the problem. Drawing labs to measure copper levels might help, but labs also may miss developing copper deficiency if it is not yet severe, or if the lab is drawn during periods of inflammation or stress, which, it can be a lot of the time for these patients. So I think that learning the patient's history and really looking at the whole clinical picture is just as important as the labs to help identify what's going on and spotlight that there may be a deficiency happening there. On the right-hand side of your screen is a case series from Dr. Blackmer at Michigan, and she does a really nice job describing their thought process on this. Once they determined that the patients had reduced copper doses in their PN, that the prescribers had been following that practice, and the hematology was showing pancytopenia, that history and those lab results really told them what they needed to know even before they had that serum copper level come back. So that's learning from kind of widespread dose adjustments that were happening. We've also learned a lot from shortage situations. So this paper describes a patient with systemic sclerosis, dependent on home parenteral nutrition due to the intestinal dysmotility. They developed anemia and leukopenia about 4 months after copper was held in the PN due to a drug shortage. And when they were able to give the copper back, things resolved. So just looking a little bit more closely, here's a chart from the paper, and this chart has a lot going on, but just to orient you, the solid black line is trending her hemoglobin levels, and the dotted line is trending her white count. And then across the bottom, we have months. So you can see here it starts with February 2011 and goes over to the right through time. So if you travel to the right from there, you can see here in September, the national shortage occurred and her multiple trace element product had to be held. Now, this patient was actually only on PN 5 days a week at that point, so she was able to eat some regular food and drink some fluids. When the shortage started, they told her to take a multivitamin with trace elements daily, but her severe dysphagia due to the disease process, it was really hard for her, and she admitted to really only being able to tolerate taking that once or twice a week. They were able to continue her individual zinc, selenium, and chromium IV, but the copper and manganese individual products were also on shortage, so she did not receive any IV copper during this period. So here we are, September that occurred. By December, she was not feeling great. She was complaining of increasing fatigue and decreased exercise tolerance, and eventually in January, they went ahead and admitted her to do a full workup of what was going on. And you can see here, looking at those trends in her labs, her white count and her hemoglobin have really tanked by the time she was admitted in January. So she had a complete workup. She received transfusions, 3 units of packed red cells. She had an EGD to rule out, was there a GI bleed or something going on? In addition to her low H&H and white count, they did do serum copper and ceruloplasmin levels, and those were found to be very low, actually undetectable. And she was diagnosed with anemia and leukopenia due to a copper deficiency. Unfortunately, there wasn't a lot they could necessarily do. This was a national shortage. They didn't have copper to give her. So they did try an oral supplement, which she was very compliant with because this had really scared her, this whole episode. Her anemia and leukopenia improved a little. And then in March, she was able to once again obtain supply of the IV multiple trace element product, and it was added back to her home bags. And you can see how quickly, March they added it back, and in April, so 2 months, 1 month after starting the oral, and 2 months after, 2 months after starting the oral, 1 month after starting the IV. And you can really see it here. She started the oral, her levels increased a little bit, but as soon as she started that IV back, it really skyrocketed back up to normal levels. One more patient. So here's another polling question. Go ahead and enter your results or your thoughts on this one when this pops up. So this one is a patient with a metabolic acidosis and suspected sepsis. So they think, it's a home TPN patient. They have a central line. They're thinking CLABSI, right? So upon further discussion with the family, you learn the patient has not been adding the multivitamin to their PN bags at home for several weeks because they've been having some itching and they thought maybe it was from the vitamins. So which deficiency do you think this would be as a cause for his acidosis? Feel free to choose more than one if you think it could be more than one. I think we have it set up to allow you to choose multiple answers. All right, so thiamine deficiency. This is another significant micronutrient alteration that has been reported in times of shortage. This is actually one of the early papers describing this deficiency when vitamins, this was like back when vitamins were not regularly provided in the TPN bag. So this first case here was an older gentleman who was admitted in the early 80s. So these are the early days of TPN. It wasn't that unusual to have TPN without vitamins. He had a resection, he had an XLAP, actually a couple, it was a little bit complicated. He developed an ileus after surgery, and they started him on TPN without vitamins. 10 days later, he rapidly developed tachypnea, hypotension, and subsequent respiratory arrest. He was intubated and found to be severely acidotic. They gave him over 1,000 milliequivalents of sodium bicarb, and he did not improve. So they thought, okay, it's not DKA, he must be septic. So they stopped the TPN, took out the catheter, and started IV antibiotics. He still didn't improve. So they went into his belly a third time with another laparotomy to find the abscess that they were sure must be there. There was no abscess. He continued to get sicker. Now he has a blood pH of 7 and a serum lactate of 27. And they have an internal medicine resident. They're like, go look at the literature and see if you can figure out what's going on with this guy. What's the cause of his metabolic acidosis? Because we cannot find it. So he did a literature review and he found some reports and suggested maybe we should look for thiamine deficiency. So they gave this patient 300 milligrams of thiamine intramuscularly. And within 6 hours, his acidosis had dramatically resolved. His serum bicarb improved from 10 to 26. The lactate went from 27 to 3, and his pH improved from 7 to 7.5. So this case really taught them, and they reported it, and it helped spread the word of this phenomenon of an acute non-diabetic metabolic acidosis resulting from this acute thiamine deficiency. So that was the 80s, and now I've added a paper there on the right that is much more current. So we've learned, we've known for a long time about this thiamine deficiency. We know to always give it, so it's not going to be an issue, right? Unfortunately, despite what we know about deficiencies, we are still sometimes in these tough situations when we cannot obtain the nutrients we know are needed due to drug shortage. And I know we're going to hear more about that later, so I'm not going to talk too much about the shortages issue itself, but I just want to show another example here. So this paper on the right is a more recent 21-year-old home PN dependent patient who was admitted with what they thought was probably septic shock. He came into the ER with hypoxia and increased work of breathing. His pH was 7.2. His lactic acid was rising. He was intubated for progressive hypoxemic respiratory failure. They were treating him for sepsis, but they did consider in this case a possible thiamine deficiency. So they went ahead and pulled a level, and at the same time they gave him 100 milligrams of thiamine. His serum thiamine level did come back low, which strengthened their suspicion that maybe that's what it was. So this chart shows the trend of his lactate level. The vertical dashed line on the left side marked as A at the bottom indicates where his lactate level was when they finished resuscitating him. And then the next vertical line marked B is where his lactate was when they administered the 100 milligrams of thiamine. So you can see once they treated him with a thiamine infusion, how quickly his lactate level began to improve. Due to the shortage, this patient had been receiving every other day vitamins in his TPN at home. He should have been receiving 6 milligrams a day, so but he was only receiving 3 times a week. So instead of getting the 42 milligrams a week he would have gotten, he was only getting 18 milligrams a week. So you can see how this kind of becomes cumulative as these shortages go on. He may have been stable for a time at home on this dose reduction that was forced by the shortage, but maybe the stress of a possible infection combined with having inadequate thiamine stores spiraled him into this acute event. So since the beginning of widespread TPN use in the 70s, we have really improved our understanding, like I said, of dosing requirements in various micronutrients through the monitoring of long-term patients and observation of clinical symptoms during periods of shortage or dosage adjustments. And we just went through a few examples of that. In 2009, Aspen had a 2-day pre-conference research workshop on micronutrients. I was lucky enough to be in attendance, and to this day, I will still talk about how it was one of my favorite talks or series of talks that I've ever attended. Excuse me, it was 2 full days of 1-hour sessions. Each hour was a different micronutrient. So there were expert leaders they had brought in from all over the world, and they each presented on their chosen micronutrient. It was really fascinating to hear all the research that had been done and be privy to the discussion between these nutrition support giants on what their opinions were on dosing requirements for all of these various nutrients. Really cool. I learned about balance studies, which I hadn't really heard of before, and how that information can really help us more than measuring a plasma or a serum level to understand if a patient is receiving enough or too much of a nutrient. After that 2-day workshop, a series of papers were written up for Gastroenterology Journal. There was 1 paper for each micronutrient presented during the workshop. Those are still really great resources to go back to. They were in 2009, but gosh, they're great information if you have access to that journal. And at the end of each paper, they even document the discussion that took back and forth that took place. So you can really follow the dialogue and read the various points that were made and see the opinions of these expert presenters, kind of like as if you were in the room. Really cool. So following that 2-day research workshop, Aspen formed the Novel Nutrient Task Force to look more closely at the evidence and recommendations for micronutrients. I already mentioned this before, and this was the initial paper. So in 2012, they published this position paper with their findings. They had reviewed the commercially available vitamin products, and they found that even though in some cases they provided significantly more than the estimated needs for multiple nutrients, they did not really see any need for dose reductions for the vitamins. The fat solubles in the parenteral product are provided at approximately the same level as the RDA, although the bioavailability probably is higher through this IV form of administration. However, the group felt that TPN patients likely do have higher vitamin requirements. You know, they've had malnutrition, they probably have baseline vitamin deficiencies. And for the patient population we're talking about today, the long-term home patient, they have chronic illness with metabolic changes, so their needs might be higher. Then the water-soluble vitamins, those were quite a bit higher than the RDA. However, they again felt that this was appropriate due to increased requirements, again, as well as urinary losses when those vitamins are administered IV. They also felt that since the vitamins of the doses of these vitamins had been essentially the same for 30 odd years by that point, and no toxicities had been described, so they felt like they had kind of proven themselves as the appropriate dose in most circumstances. They did call out vitamin D specifically, and that the dose of 200 IU for adults may be inadequate in some situations. And they recommended an IV product to be developed for patients that do become vitamin D deficient and fail to respond to oral supplementation. However, to this day, as you know, we still do not have an IV form for our long-term home PN patients. So that's the vitamins from this report. For the trace elements, they had quite a bit more to say. So we're going to focus in on that a little bit more. So since those early guidelines, the recommendations for significant reductions in both copper and manganese had not been addressed. They felt that the commercially available products needed to be updated to reflect the updated recommendations for those nutrients. And they also discussed that trace element contamination of the solutions was a significant concern, and we'll talk more about that in a minute. All right, before we move on, I want to have one more polling question. This is just really I'm curious to see what general practice seems to be out there. So for this one, you can answer it anytime whenever it comes up. I won't wait, I'll go ahead and move on, but just go ahead and select all of the trace elements that you tend to provide to most of your patients. So this is definitely a select all that apply question. So let's take a closer look at the trace element dosing recommendations. This chart summarizes the major guidelines updates that we've had over the last 20 years. And inside the box to the right there that I've highlighted are what have been included in that PN dosing guideline sheet from Aspen. You probably are all familiar with that. It's that one pager that you can print front and back. One side is adults and the other side is pediatrics. It's such a great resource. It came out, I think, originally in 2019, and then there was a slight update made to it in 2020. It's available on their website. If you're not sure what I'm talking about, definitely reach out to me. I will help you find it. If you are writing TPN, you definitely want it in your pocket or saved on your desktop. It has all the dosing guidelines right there in one quick sheet for you to refer to, so it's great. All right, so looking at the guidelines there and then opening it up to what we now have available today for an available US multi-trace product. You can see the 4 trace elements that are included: selenium, zinc, copper, and manganese, and they match up pretty well against those dosing recommendations. There may be situations where your patient requires more of one of these. The first thing I would think of there is zinc, right? There may be, our long-term patients who experience significant GI losses that we know they're losing between 12 and 17 milligrams of zinc in every liter of stool or ostomy output. So you can see in those situations where 3 milligrams a day might not be enough. So some patients may require additional, in which case you would dose, in this example, additional zinc on top of the multi-trace product. What about these nutrients that have recommendations made for them by some groups, but are not included as part of this commercially available product that we have today? So in the interest of time, I'm just going to focus on kind of the 2 most important ones of these, chromium and iodine. So first, let's talk about chromium. I'm in kind of a unique position. I've worked in a hospital for almost 20 years, and I would see what we did, but now I'm in home infusion, so I get to see orders coming in from all over the country, and I kind of see a little bit more what practice is like all over the country. And I've been really interested to see in the last year a significant amount of orders coming in that are requesting that chromium be added to the TPN since it's no longer included in the new multi-trace product. So I'm just curious if this practice is warranted or not. We do have some case reports that seem to correlate chromium deficiency with hyperglycemia or insulin insufficiency. So are we at risk for causing these clinical symptoms if we don't provide additional chromium since it's no longer in the multi-trace product? This was a study published in 2019 where they tested various components that are added to the TPN to determine how much trace element contamination there was in each product. So they tested 32 unique components, 65 products in all, and they were looking to see how much manganese, chromium, selenium, zinc, and copper contamination there was from these other additives that are put in the TPN bag. Contamination with trace elements was detected in 75% of the tested components. The highest contamination were chromium and manganese. Chromium was found in 66% of all components and manganese in 52% of all components. So the authors of this study recommended once again that the multi-trace element products should be reformulated to eliminate chromium and decrease manganese. This is another interesting look at contamination of PN solutions. And this group, really cool, they looked at pediatric patients in this case, and they actually tested the bag. So they went straight to the source, what is actually being infused in these patients. So they had patients coming into the clinic, so home patients who came into the clinic, or they also looked at the bags of patients that were admitted to the hospital. So they would collect those discarded TPN bags after the infusion was completed. There's always a bit left in the bag with overfill and such. And they were able to sample the contents of those bags to measure the amount of contamination that was there, that was truly going into a patient. They collected samples from 72 patients. 39 of them were in the hospital and 33 of them were home PN patients who had come into the clinic and brought their bag in. They found chromium contamination actually accounted for over 100% of the recommended dose that patients 0 to 12 months should receive. And then the age is broken out from there, and you can see it's between 64 and 93% of the recommended dose for the older children, just depending on how old they were. So the younger they were, the more contamination actually fulfilled their daily needs without them even receiving a dose. So as we make determinations on whether to add chromium at all, or if the amount provided as a contaminant is enough to meet the patient's needs without actually needing to purposefully dose any, we really need to have a better understanding of what the ramifications are of chromium deficiency or toxicity. There have been some selected populations where chromium supplementation was reported to have a positive effect on hyperglycemia. We know that chromium is a cofactor for insulin function and enhances the effectiveness of insulin. There have also been reports of peripheral neuropathy, so there could be something there with a deficiency. As far as toxicity, there have been studies in PEDS patients showing an inverse relationship between GFR and serum chromium concentration. The longer patients were on TPN and the larger their cumulative parenteral chromium intake became and the higher their serum chromium level went, the worse their GFR was. In one report, the investigators discontinued parenteral chromium supplementation, and 1 year later, levels were still elevated. And I can tell you, I found the same when I was working in PEDS in the hospital setting and writing TPN for these home patients. You know, you can discontinue, and I'm sure plenty of you are in the same situation. You can discontinue these, and years later, they still have elevated levels. So in this study, the elevated levels, they definitely correlated with the GFR, and the GFR continued to be below where it should have been, with age-matched controls indicating possible long-term or irreversible kidney damage. Since we know that chromium is delivered to the patient at fairly generous levels due to this contamination, and there are some reports of possible negative effects from the high levels, the new reformulated multiple trace element product seems appropriate with no chromium provided. I would suggest not giving a separate chromium unless a deficiency is truly suspected. But we should be careful about just doing things because they've always been done that way. Like, oh, it's always been in the trace element, now it's not, so let's add it. Like, let's ask more questions there and look at what we're doing, look at our practice all the time, because we're constantly learning on this stuff. What about iodine? So Aspen had not included, as you can see there, iodine in the recommendations. It was included by some other groups. Our Aspen authors felt that it could be beneficial, but really more research was needed before they could recommend adding it to the multi-trace product that might be developed. In the past, Povidone Iodine products were used for antiseptics, which may have provided enough iodine to prevent deficiency. Now that Povidone Iodine antiseptic solutions have largely been replaced by chlorhexidine, patients are certainly receiving less iodine exposure and could be at a higher risk for deficiency. There have been pediatric cases of hypothyroidism resulting from iodine deficiency in PN-dependent patients. This one in particular that I pulled was a pediatric patient exclusively on PN for 7 months. Thyroid studies were done and he was found to have hypothyroidism. Once they were able to resume some enteral, which did provide the daily recommended iodine intake, the hypothyroidism resolved, so kind of a correlation there. So this is probably going to be more likely in pediatric patients, right? Because they have smaller stores, but it could certainly happen in long-term adult patients as well. So I think it's something to consider in the differential in a patient with unexplained hypothyroidism. And again, it's, due to our changing practices with antiseptics, it's like we just constantly have to be looking out for things that didn't used to happen, but maybe will happen now. So it's just something to keep in mind, just another question to ask yourself. Could this have anything to do with it? So labs are great. We all like to have a lab and get our answer, right? Yes or no, it's high or low, whatever. But we know that labs, unfortunately, are not really that accurate in a lot of situations. So we do need to listen to our patients and make sure we have a good understanding of their history. What has their intake been like? And for how long has it been like that? What has their disease process been like? What are their clinical symptoms? what kinds of things have developed since they've been solely dependent on TPN. We want to make sure we're keeping an eye out for clinical signs of deficiency or toxicity of micronutrients. And I just pulled this chart together from different sources. I was looking through the core curriculum, and I think that many of us pull out the core every 5 years when we need to retake the CNSC and refamiliarize ourselves with all of these symptoms, right? But we really do need to try to keep these on our radar and be thinking of these signs and symptoms for our long-term HPN patients. And speaking of the core, I was in this chapter, so I pulled out this quote at the bottom that I really liked. I think it really summarizes the theme here. A nutrition-focused physical assessment should be used to identify nutrient deficiencies in tandem with the appropriate biochemical assays. In addition to the core, there are some good papers out there. I just put this one as an example. This was in NCP a couple of years ago, and I love it because it's got a great collection of images to really illustrate these clinical signs and symptoms that are seen with various micronutrient deficiencies. All right, so manganese. We can try to evaluate labs, and we can listen to our patients and ask pointed questions to try to get a good understanding of their history. And we can monitor for clinical signs and symptoms of deficiency or toxicity. And hopefully, with all these methods combined, we can get a handle on what the requirements are and whether or not we're providing enough or too much of these various nutrients. There are, though, sometimes we have a little more definitive proof. So I like these studies that really have pretty strong evidence. You know, they're not just correlating and saying, well, we did this and then this got better, so we think it was this. I mean, this is pretty definitive stuff. So this is an example of that. This was a study where they looked at 16 patients who were receiving long-term HPN. Whole blood manganese level was measured and brain MRIs were performed. So they had 16 patients in this study. These were adult patients. They were between 18 and 83 years of age. Short bowel was the most prevalent diagnosis. 5 of the 16 patients had a PN-associated liver disease. And they were on PN a combination between 3 days a week to 7 days a week. The average across the whole group was 5 days per week on PN. And they had been on TPN from 1 to 26 years. The average duration was 9 years on PN. So 50% of these patients had elevated manganese levels, so they had a biochemical or lab sign of toxicity. However, when they went in and looked at their MRI results, the prevalence of significant manganese deposits in the basal ganglia was more than 80% of the patients. 2 patients with MRI signs of toxicity had a clinical diagnosis of Parkinson's disease. 66% reported depression, 42% reported lack of concentration, 17% reported memory disturbances, 8% reported gait instability. So the neurological signs went along with what they were finding on the MRIs. Out of the 3 patients who did not show these signs of manganese toxicity on their MRI, 2 of them did not have any manganese in their TPN, and 1 was only on TPN 3 days a week, so not getting a lot. We also have some definitive signs of toxicity from this research. So this was that Ole sponsored research from several years ago. This group evaluated autopsy tissue samples from 8 long-term home PN patients. The autopsies were done over a period of 10 years. 7 of these patients had discussed this study with their clinicians and gave their advance permission to participate in this study before their death. And the 8th participant died suddenly, and his parents gave permission for the autopsy. The 8 long-term patients were on TPN for short bowel, either from Crohn's disease or a mesenteric infarct. They had been on PN from 2 to 21 years, with an average duration of 14 years. The trace element levels in these 8 patients were compared with 45 control subjects that had been studied and published earlier by the same lab. The controls were a mix. There were young, healthy accident victims. There were elderly patients who had died without any chronic bowel disease and had never been on any type of artificial feeding. So that was the control group. All of the home patients had received the standard amounts of trace elements. And then they were all at one center, so they had their standard practices. So they were giving additional zinc at a replacement dose of 3 to 5 milligrams per liter of GI loss. There were 2 patients who died from liver failure, and they both had their PN, copper, and manganese discontinued when their serum bilirubin levels started to rise. All right, so this is a chart from the paper, and of course you can't see all of the detail on there, but this does list out all of the trace elements that they received, the doses of each, and then what I did was just summarize the sample results in the chart below. So the samples from the 8 patients, again, were compared to the samples from the control patients who had never been on TPN. Zinc was normal compared to the controls in heart and muscle. It was occasionally elevated in the kidney and frequently elevated in liver tissue. So again, zinc is the one where these patients were all receiving a standard trace element product, but the zinc was actually given a little bit extra according to their practice guidelines. Copper was normal in heart and skeletal muscle, but very elevated in liver and kidney, especially those who had died in liver failure. Manganese was elevated in all tissues, but especially in liver and kidney tissues in patients with liver kidney disease. Chromium was significantly elevated, 10 to 100 times higher than normal concentrations in nearly all of the tissues studied. So the results from this study are really important, and they have added to our growing body of evidence that we were giving too much chromium, too much manganese, and probably too much copper for these long-term PN patients. We haven't talked about aluminum yet, but I can't do this talk without bringing up aluminum. So we're certainly not purposefully dosing aluminum, but I think it's important to mention it in any discussion on micronutrients. So this is another paper that is actually reporting on those same patients we were just talking about and their autopsy results. 7 of the 8 patients also had bone samples available for analysis, so they were included in this postmortem analysis of micronutrient deposits in bone. So this group compared the autopsy bones from those 7 patients with living controls. So these were patients who came in to have like a hip replacement or a knee replacement. They had normal GI function, normal renal function, and they had bone samples from those patients. And they compared those to our 7 very long-term home patients. So, all right, to orient you to this chart, the blue and red bars on this chart indicate the aluminum concentration in the bone samples. If the bar is red, so these are, each one of these bars is a patient, our 7 patients here, 1, 2, 3, 4, 5, 6, 7. If the bar is red, it indicates the patient had renal impairment as part of their disease. The green bar over here is the control group, so 0. And the numbers across the bottom are the number of years on TPN. So our control group was not on TPN. We have a patient who was on for 2 years, all the way up to a patient who was on for 21 years. So you can see, just eyeballing this chart, the significant elevations of aluminum content. 6 of the 7 patients were significantly elevated statistically. The 1 patient who here did not have the statistically elevated levels had been on TPN for the shortest amount of time, 2 years before his death. So again, the patients who had some type of renal impairment, you can see that they tended to have even higher levels of aluminum accumulation in their bone. And we know that aluminum interferes with bone formation, probably by interfering with osteoblast activity and reducing PTH secretion. Our home parenteral nutrition patients are at risk for osteomalacia, osteoporosis, bone fractures, metabolic bone disease. So for those on longer term home PN, aluminum contamination can certainly be contributing to those risks. The average aluminum content in the control bones here was 2.6 micrograms per gram of dry weight, and these PN patients ranged from 4.9 to 56. So 2 to 20 times higher aluminum deposits in their bone than the healthy controls had. So I bring this up because, again, I think it's an important topic whenever we're talking about micronutrients. But we really want to keep this in mind when we're dosing TPN for our long-term home patients and just try to minimize this exposure wherever possible. So I brought up a lot of different papers and kind of told some of the stories of some of these patients that we've learned from through the years. And to start to wrap it up here, I'd like to take it back to the most important thing, which is our patient, the person at the end of the line. We really get caught up in which lab should we check and how often should we check it. I'm sure that we all have our own charts of the frequency of lab monitoring, and we're keeping an eye on that. But we know that we don't really know what those labs are showing us. We don't know that, we can't always trust that it's a true, accurate representation of whether our patient is getting enough or possibly too much of a nutrient. It's not always easy to check these lab values at home either. So we're talking about home patients here. We can't just draw some blood on the floor and send it down to the lab. So let's bring reality into it for a minute. So depending on where the patient lives, how long it takes for the nurse to get to their house, and then when the nurse leaves their house, how long does it take them to get that lab specimen to a location where it can be spun down and processed appropriately, and then to the lab for analysis. It might be a special tube top that's needed for this trace element lab. So there's a lot to it. It's definitely a struggle. It takes a lot of coordination to get these labs drawn at home. Another thing that can be a struggle at home is having to inject a lot of different additives into the bag each day before hanging. So when we're talking about home patients, we need to always consider the stability data we have. When in the hospital, it's not such a big ask to just add some extra thiamine or whatever vitamin to be helpful. It might help, it won't hurt, etc. I know we've all said that probably in our heads before. It's easy enough to do. Let's just go ahead and give some. At home, though, we need to consider the stability data. Is that nutrient that you would like to add stable in that PN solution for 9 days, which is the stability required when we're shipping a week's worth or delivering a week's worth of TPN at a time to the patients? So if it doesn't have that 9-day stability in the PN admixture, does it have syringe stability? Meaning, can it be pulled up into pre-filled syringes, which at least makes it a little bit easier for the patient. They could have this week's worth of pre-filled syringes of their various vitamin additives that need to be pushed into the bag right before hanging. So for those of you who might not know, they already do have to add their multivitamin product that's not stable in the bag. So each day they are pulling up 2 different vials of vitamins and inserting those into the bag before they hang their TPN. And then if we have them on any additional vitamins, those will have to be drawn up and infused into the bag as well. So if they have syringe stability, what that means is they can be drawn up by the pharmacy under the hood and in sterile conditions, and can be pre-drawn and pre-dosed, and all the patient has to do is push that syringe for that product into the bag. But a lot of the vitamins don't have that syringe stability. So then you're sending the actual vial. I just have some examples there so you can kind of visualize what this looks like without any brandings. So you can send the vial, and then the patient has to take a syringe and pull up that product and pull up the correct amount and then inject it again into the bag. So of course, if they need to have these things, definitely, write them the order that they need to have. But I do think it's important for us to just think about what this is like from the patient perspective as we're coming up with our perfect clinical order. Let's just think about what this is going to be like for the person at the end of the line at home doing this every single day. And I want to finish up by bringing it all back home. So this is the last slide, but it really should be number 1. I mean, it's the most important thing, I think. Safety is the number 1 factor that we should always keep at the forefront of our minds when we're doing anything with the TPN. We know that TPN is a very high error rate therapy. There are so many different additives, so many different lines on a TPN order form where an error can be made. We are all human. Humans make errors. There's no doubt about that. There's no human that doesn't make errors. That's why we have all of our double checks and triple checks and everything to try to catch them as much as we can. But every single line item that we have in TPN is the potential for an error. So, you know, we have different units used. We might have micrograms or milligrams. There are often decimal points in these trace elements because they're small doses. Could we round, or do we, you know, must we have that decimal point there? Because sometimes things are faxed over. You can't really see. It could be easy to mistake where the decimal point is at. And these are things that have resulted in fatal errors. It's just like electrolytes. The more complicated it is, the more likely there is to have an error. So the less complicated, the better, right? So like for electrolytes, for example, I personally tend to dose all of my potassium as KCl. I know some people tend to dose all as K-acetate. I think the important thing there is to try to pick one source of potassium if you can, and then adjust the other things, adjust the phosphorus and adjust the acid-base balance in the sodium additives instead of the potassium additives, because potassium has a much higher potential risk for error. And if an error occurred, it would be much more significant. So if you accidentally gave 50 more of K, that would certainly be more significant than 50 more of sodium. So just trying to make things simpler and less prone to error is just always something to keep in mind. I've been writing TPN for a really long time, and I've always used individual trace elements for the long-term home patients in the past because I didn't want to provide excessive amounts of certain additives. You know, we kind of have known that we didn't have great products for a long time. So as soon as someone declared themselves as a long-term patient, especially in pediatrics, we were quick to put them on individual products, right? I think a lot of you probably practice the same way. So I think now, for the first time, we have a product finally that aligns with what the recommendations are. So we can look at giving this product and not having these individualized ingredients that are putting us at higher risk for error. So I would just encourage you to keep that in mind, keep safety in mind, of course, and take a look at your ordering practices. If you are just like I was, and you know, you've kind of always done things this way and you're really comfortable and familiar with those doses, just kind of start to take a look at some of your patients if you haven't done this already and see what you're giving them compared to what this newer multiple product would add, and see if it's possible for a lot of these patients to maybe just go ahead and switch them over for safety, if nothing else. Just make a safer, simpler order that is less of a risk of some of these things happening. So that's the end of my line. This is so I'm in Colorado. This is a mountain nearby me, and this is where the track ends at the top of the mountain. So I hope you have enjoyed this little trip through time, and we'll keep some of this research in mind as you make decisions about dosing micronutrients in your patients. I don't want to necessarily, you know, provide all the answers, and we don't know all the answers, but I think it's important to look at this stuff that we've figured out through the years, and kind of it helps us to ask the right questions, or to think about things in a new way, or to really just, you know, I know people talk about the sacred cows, or we've always done things this way and it's felt pretty safe, but if there are new products available and new information coming out, we should take a look and kind of just make sure that we're doing things with safety, number one, in mind, and trying to dose our patients as simply as we can for their life at home. All right, that's it for me. Thank you so much. I don't know, I can't tell if there's any questions coming in, but I'm happy to try to entertain some questions. I think we have another couple minutes here.
Hey, Jessica. I want to say thank you so much. That was an excellent presentation. I appreciate you sharing your expertise with us. I do have questions for you. I can see them, so I will pose them to you and have you answer them. The first question that I have is, how deficient would someone have to be to exhibit metabolic acidosis from thiamine deficiency?
That's a great question, and that takes us back to this whole question of what is the meaning of deficiency? Is the meaning of deficiency that their lab is showing it, or is the meaning of deficiency that they have these clinical symptoms? So the patient that I showed, and some of the case reports that have been reviewed, it looks like it happens pretty quickly. Whether or not the serum level keeps up with that, and whether or not you would have the serum level quick enough to be able to help you in your differential when you're trying to figure out what's going on with this patient, when you're in the hospital setting, it could be one of those situations where it's probably not going to hurt to try to give them some thiamine. You could draw a level. It's kind of like antibiotics when you think they have a eclampsia. Make sure you check the culture first and then go ahead and give it so you have your answer. So go ahead and check the level. You won't have a result back yet, but why not just give them a dose of thiamine to try to see if that helps with what's happening to them acutely.
Okay, great. Thank you. Second question, outside of having an elevated level on a lab, what are the top conditions or disease states that you would consider holding a multi-trace element product for, and how long?
Oh, that's a good question too. I think, gosh, I mean, I don't know that we all know the answer to this, and it's interesting with this new product that's come out. We haven't had it long enough to really know what the ramifications of that are going to be. But looking at historically what we've had, and it depends on the age population you're working with too. If you're working in the NICU population, you may say, okay, if they're on TPN for at least 2 weeks or at least a month, we're going to go ahead and adjust to these individual products. For adults, you might wait a little bit longer to see if they're going to declare themselves, if you're not sure if they're going to be a long-term patient or not. But if it's a patient that you know is going to be long-term, I think in the past, I was generally pretty quick to go ahead and put them on the individual trace element products, just because we had some long-term lab results on our own patients and looking at what the literature out there was showing us. And so we wanted to be careful about, I always used to say, I think by the time they've been on TPN for 2 weeks, at least this was for the littler patients, by the time they've been on TPN for 2 weeks, and gotten a standard trace element product, they probably had enough chromium and manganese to last their lifetime. So we wanted to switch them out pretty quickly. But with this newer product, I think the jury is still out. It follows what the recommendations have been in for years. So I'm hopeful that we won't have to make these changes as often, and that we can do a simpler product. I mean, these safety things, those fatalities are scary, and they've happened a lot, and a lot of them have been with micronutrients and individually dosed trace elements. So I think if this product conforms pretty closely to what we think they need, let's go ahead and give it a shot and then see what happens, and we can reevaluate and see if things need to be changed further down the road again. But I'm so excited that, I mean, I just can't say enough how happy I am that we finally have another product in the mix, right?
Yeah. Okay, you mentioned the challenge of checking labs for the home parenteral nutrition patient. I have a question here for the inpatient setting. After how long a patient has been on TPN, should we consider checking micronutrient levels? Some patients end up staying inpatient for much longer than anticipated due to social or insurance issues.
Yeah, that's a good question. I think if they're in the hospital, I would say in general, people tend to stay every 3 months or every 6 months. If they're in the hospital and they're kind of hanging around because of social reasons or insurance reasons, like you said, and they're not actively like stressed and infected and all the things that we know alter the lab values, I would probably go ahead and check one. If they're still there at the 3-month mark, go ahead and check those levels so you have a baseline in the hospital. You're not having to deal with all of the extra complications of trying to get those results at home. We did try, when patients were readmitted, we would often try to go ahead and get levels while they're in the hospital, even though we know if something acute is going on with them, the levels might be less accurate. But if they're admitted for something else, or they do hang out in that admission for an extended period and they seem to be fairly stable and not stressed and not infected, great, go ahead and check those levels before they go home or before they go back home, just because it is so much easier. And what you can do is check a CRP at the same time, so that when that comes back, whether or not you should kind of take them with a grain of salt, or if the CRP was normal, maybe they're a little more accurate.
That's great advice. I have 2 more questions for you. For long-term home PN, what is your strategy for iron supplementation?
Great question. How to answer this? I don't want to talk like off-label and things, so But yeah, we don't have a lot of options for that. So when that does come up, I can say in my own personal practice, I try really hard to find other ways to give iron. I really, I've read and listened to Dr. Dedrick talk about trying to put together TPN formulations that stay together, and looking at the 2014 Aspen Safe Guidelines for TPN that Dr. Bulata and others put together. We know that divalent cations and trivalent cations pull TPN apart pretty easily. So that's why we monitor the amount of calcium and magnesium that are in a bag, a 3-in-1 bag, because those are divalent cations and can certainly affect the stability of the emulsion. And then you have iron, which is a trivalent cation. So I really try not to add it to the bag as much as possible. Certainly not a 3-in-1 bag. I know that there are some people who add it to a 2-in-1 bag, but I think that it's good practice wherever we can to try to give it separately. So there are different products on the market. So I would say, do some more investigating there and handle the iron separately from the TPN. That's at least my practice.
Awesome. So last question, how would you minimize aluminum exposure?
That's a great question, and it kind of goes beyond what we were talking about today. So there are some things you can do within the electrolytes as well. I don't ever use K-phos unless I absolutely needed to, because maybe there was a shortage or something. So sodium phos products tend to have less aluminum contamination than the K-phos products. So you can just look through your products and understand what the amount of aluminum is in there, so you can try to choose wisely wherever possible. However, there's only so much you can do. Calcium is a huge contributor as well, and we're certainly not going to remove that or take that out, and we don't have a lot of choices there on which product to use. But where you can, try to make adjustments. And then I think the other thing with that is just to remember that when we tend to think of, well, this could help and it won't do any harm, but there are some harms, right? If we do add some different products in there, potentially they could be adding to the aluminum contamination. So just think about that. If you are adding something, it doesn't seem to be working, let's go ahead and maybe take it back out, so we're not possibly adding to another thing that could increase the aluminum exposure for that long-term patient that is at risk for metabolic bone disease.
Awesome. Thank you so much. That is all the questions that I have for you. Once again, I appreciate your presentation and enjoyed it very much.
Thank you.
Hi, my name is